FAVMI presents Unfolding Mental Illness, hosted by Saraswati Suresh.
Me India. Through these episodes and podcasts, we tend to bring about tools and resources, inputs from experts, inspirational stories. And we believe that these can help the family carers and our loved ones for a better understanding and also bring more awareness in the society. I am Saraswati Suresh, the founder of FAVMI and the host for today. And I have with me Dr. Sachin Ganorkar, the co-host, who's also the director of FAVMI. Our episode today is Ask the Expert. So for a long time, we've been seeing a lot of our family carers and our loved ones asking a lot of questions every time. So we decided, let's collate these questions and put it forward to our experts. So we received a lot of questions. Of course, we can't cover all of them in this one episode. So we would be covering part of it in today's episode and then take it forward, the other questions in another episode with us. Thank you so much to all my audience who have shared their questions with us. And I hope we are being able to bring the answers that you are looking for. Our guest for today is Dr. Krishna Prasad, a young, dynamic, and a very well-known psychiatrist from Bangalore. He did his MBBS from Bangalore Medical College and then went on to do his MD in Psychiatry from NIMHANS. Today, he's a professor in NIMHANS and heads the Psychiatric Rehabilitation Services in NIMHANS. Thank you so much, Dr. Krishna Prasad, for agreeing to join us today and share your inputs for the questions that have been asked by the audience.
Thank you, sir. Thank you.
Yeah. So starting with the first question, was how does one actually diagnose that, their loved one has a mental illness and we need to take them to the psychiatrist? Many times we realize that, the families that, we don't understand what is mental illness. So, you take time, you think they're lazy, they're stubborn, they're just behaving something like that. It just we don't really understand. It's not something which is very known to us, like a fever or, a malaria or, things like that. So how does one realize and take them to the psychiatrist?
So generally, what happens with most mental illnesses is that there will be changes in behavior, there will be changes in thinking, or there will be changes in mood that are sometimes very easily recognizable in the case of severe mental illnesses, or sometimes not so easily recognizable in the case of, say, for example, so-called common mental disorders like depression or anxiety. Mm-hmm. So doctors make a diagnosis primarily based on the history that is provided by the person who is affected by the illness and the collateral information that is available from the family. What happens usually is that people with the mental illness sometimes do not realize that these are changes that are happening in them. The family, as you mentioned, sometimes recognizes these to be qualitative changes in a person's mood or in a person's behavior, and thinks that this is being intentionally done or a part of a volitional pattern of behavior. So that leads to some delay in recognizing that these are problems that need to be dealt with as a part of an illness. So typically, fever is something that is very objectively seen, very easily recognizable. Other illnesses, say, for example, injuries are very easily recognizable. But mental illnesses are slightly different in that sense that it takes some time before people realize that these are some things that they should need consultation for. So I think there are these changes that people think or assume to be a part of normal pattern of life or a normal course in one's life. And that may lead to delay in diagnosis. So typically, people with severe mental illnesses, say for example, if you take schizophrenia, they would have changes in their thinking in terms of believing some things that are actually not true, what we call as delusions, or they may have perceptual experiences of, say, for example, commonly seen experiences are hearing voices of people when there are none. So these are changes that they may share with their family members, they may not share with their family members. Sometimes acting on these beliefs or acting on these voices may be only something that is noticeable to the family. For them, these may be real experiences. So it sometimes becomes a challenge for them to realize that these need help. And I think that's where the problem sometimes lies. Similarly, people with the bipolar disorder may have qualitative changes in their mood to begin with. It may start off with either depression, or sometimes it may start off with mania. So I think each of these will have characteristic symptoms, and doctors generally tend to make a diagnosis based on history and their observation of the person.
Thank you. So also we have noticed that, the family does realizes these mood behaviors and, behavioral changes, but the patient refuses to go to a psychiatrist. There's a complete denial that nothing is wrong with me. So how do you take them to the psychiatrist? I mean,
yeah, it's not easy because, as I mentioned, for the person affected with these issues, it may actually seem very real. For example, the perceptual experiences or the beliefs that one may have surrounding, say, somebody harming them, somebody following them, or say somebody making some signals that are specifically meant for them. So they may believe that these are actually happening in their life. So to tell them that this is not true and to take them to a doctor, it may not be an easy job for a family member. So it is definitely a challenge. Whereas, for example, with the issues, say, surrounding anxiety, or issues, say, surrounding feeling low, or feeling helpless, even there, people are reluctant to take a consultation because they believe that this is probably a sign of weakness if they talk to somebody about it, or they may simply think that this is not an illness. So it is definitely a challenge sometimes for the family to recognize and to also to convince the person that you need a consultation. What may sometimes be helpful is that when it is tied to some immediate need of a family member affected, I think that is when, say, for example, if the sleep is disturbed, or if, say, other issues, say, surrounding achieving a particular goal in their life is affected, I think making those as reasons to convince the person to take consultation may be easier, rather than directly saying that you are not having, you are having some experience which is abnormal, or you are not behaving all right. I think these are things that may kind of make a person defensive and not accept that the person requires consultation. So tying it up to a need that the person has in terms of the life goals, or say very immediate disturbances like, say, sleep disturbances or appetite disturbances, may be more easier to deal with than, say, directly confronting and saying that you. There are people who recognize the change that they have, and they do seek treatment, and there are also people who flatly refuse that these are symptoms of an illness. So it is on a spectrum. So it is easier to convince some than others. So I think it's a challenge sometimes for family, and it takes years sometimes for people to understand that. And even there are people who may never understand that these are a part of an illness. So it is along the spectrum that you see people having these challenges. And we recognize that sometimes families do have to struggle a lot to deal with the people who do not have insight into their illness.
okay. That's a lovely input which you have given, sir. Putting the need and, the small symptoms rather than the actually bringing out the disease in front of the patient. I think that's a lovely input to our families. I'm sure they will take this forward. So what is the difference between denial and insight? Or are they the same thing?
I think it is a part of denying that one is not having an illness is probably lying on the spectrum of insight. I mean, people can have full insight into their problems. They may accept that they have an illness. They may be aware of the changes that is happening. They may accept treatment. People may simply believe that this is a part of, say, some experience that is related to either a religious experience or some supernatural explanation that they may provide. So I think denial is complete lack of insight sometimes, and sometimes in the context of the family, it is probably it's a response to this drastic change that they notice in the family member, and they may think, oh, why is this happening with me? So it's not me that is being affected. It's not my son. It's not my brother. It's not my sister. So and looking at the gravity of the diagnosis that they may suddenly confront with, I think they may sometimes refuse to believe that this is an illness and they need to take treatment. But I think gradually over a period of time, that degree of acceptance in the family member develops in most. Some, of course, continue to grapple with the challenges about whether this is actually mental illness. So we do see family members who continue to think that there may be some other explanation for the change that they observe in their family members. So it's a host of things that people experience and people believe as a result of these experiences. So I think you don't have a single explanation why people may have these ranges of beliefs that they have.
Okay. So the next question, which one of the audience has asked us, family carer have asked us, is: can mental illness like bipolar, schizophrenia, etc., be completely cured?
See, we do see when we look at the longitudinal course and outcome of both schizophrenia, bipolar disorder, we do see people who have a single episode and never go on to have episodes. But a vast majority continue to have symptoms in one form or the other. Some of them have episodes. See, for example, in the context of bipolar disorder, they may have repeated episodes of mania or repeated episodes of depression, or sometimes what are called as mixed episodes. And in the context of schizophrenia, they may never really get better. A fraction of them, at least 1/3 of them, may not experience a significant relief in their symptoms. Similarly, with bipolar disorder, there may be people who may have discrete episodes and inter-episodically may be completely functional and maybe achieving whatever they desire in their life. We also see people who grapple with sub-threshold symptoms, symptoms that are not very recognizable but may not be feeling really good. They may have sub-threshold depressive symptoms. They may continue to experience some degree of mood changes in between. So not the optimal level of improvement that they would expect in between episodes. So again, there is a vast difference in the outcomes for different people. And there could be several reasons why people may not have the optimum outcome that they would want. So typically what you see with bipolar disorder is it is a recurring illness. You do have repeated episodes, but then there are a fraction of people who may experience a single episode and may never experience another episode. Similarly with schizophrenia, vast majority do continue to have symptoms, and it is recognized that both of these diseases in many of the people that experience these actually have a chronic illness.
Okay.
So if you look at cure, is there a analogy if you say, for example, take with hypertension or say diabetes, you don't really expect a cure for diabetes, or you don't really expect a cure for hypertension. So in that context, I think one has to understand that many chronic illnesses, very similar to mental illnesses, don't really have a cure that way. But I think the quality of life of people having these problems can be far better if whatever is known about these illnesses and their treatment is adhered to.
Okay. Yeah. So coming on to medications, we see that, patients refuse to take on medications, and, families have to give it to them without their knowledge, or, at times they just stop and then the relapses happen. So how do you convince patients to take on medications?
See, the fact that we'll have to take medications for a long time, and the fact that sometimes there are more than one medications to be taken, it's not easy for anybody who experiencing a problem to take medications for a long time. So even if it is for a matter of 3 months, how many of us remember to take medications? And also, there are so many issues surrounding medications. One of it is the fact that we do experience side effects. Some of them are known, some of them are very subjective experiences that people have. Say, for example, when we prescribe antipsychotics, it is very easy for us and sometimes for the family to say that take this. But sometimes people report very, very much subjective challenges. Say, for example, I am slowed in my thinking. I am not able to say experience all the joys of life because it is making me numb. So some of these are very subjective experiences. So I think we sometimes tend to discount these subjective experiences, both the family as well as the doctors, and think that it's simply a linear thing that you simply have to take medications. So at the same time, we also see people who lack insight, and they may feel that I am not ill. The experiences that are happening to me are actually real experiences, and why should I take medications for these? So this could also be a challenge. So with, say, for example, bipolar disorder, repeated episodes over a period of time, we do see some patients getting convinced that there are changes that are happening in me, but then that acceptance to an extent may develop, to an extent may not develop. They may take medications, not really convinced that this is an illness. So, but this may happen over a period of time. Similarly, with the schizophrenia, also we do people after repeated admissions may realize that we need to take medications. But as I mentioned, like it was with the consultation, first consultation with the doctor, I think similarly with medications also, tying it up to immediate needs. I think addressing the concerns that the person experiencing the illness and taking treatment has with the medications, I think that becomes more important. Also, sometimes what happens is every small symptom is pathologized. Every small symptom is categorized as a experience of illness rather than a normative experience. And I think adding to the burden of medications that people may take. Why should I take 10 medications? I am taking three medications three times in a day. So it is challenging. And of course, taking medications in front of others, it can be embarrassing. If you are at workplace, if you have to take medications. So all of these can become challenges. Sometimes people have challenges reaching office on time because medications are causing excessive sleepiness. So they're not as productive as before. So sexual side effects. These are some things that people may not wish to share with others. So I think all of these can be challenges, and I think openness in discussion around these should be encouraged. And I think both as professionals and as family members, I think openness to discussion surrounding difficulties rather than simply confronting or saying that why are you not taking the medications would probably be more productive in terms of the experience that the person who has the problem has, as well as for the family. I think that could be something that could change.
That's a lovely message to family carers, actually. That's true. If you push it rather than making it more understandable to the family.
I think a discussion surrounding the challenges the person has may be more productive. It may not be very easy. It may require some degree of persistence without being very annoyed or without being very confrontative. I think it's a challenge. It requires immense patience, and we do see families who are immensely patient and try to help their family.
Yeah, I cannot tell you how much one has learned patience in their life. With this, it's been the biggest learning, I think, for all our family carers. Actually, I mean, I'm one of them, so I say that it has been for me too. Yeah. So, in fact, one of the questions they have also asked is, which you spoke about, is about side effects. So lifelong medications cause side effects. Are there any other alternatives to medications?
See, the mainstay for both bipolar disorder and for schizophrenia, both from the point of view of mitigating symptoms as well as from the point of preventing a relapse, I think the mainstay is the treatment with medications. Now, the issue is that over a period of time, during the acute exacerbations, there may be a requirement of a greater number of medications just to bring down the acuity of the symptoms. But over a period of time, I think in consultation with the doctors, I think the number of medications can be reduced, and the dosage of medications can also be reduced to what is called as a maintenance dose. So it's only a small fraction of people who may require multiple medications for a longer period of time. So I think it has to be done carefully, and I think one has to discuss this with the doctor depending on the individual situation that the doctor and the patient experience. I think that has to be done carefully over a period of time. So it is definitely difficult to take a lot of medications for a long time. And I think all of us will vouch for it. It's not simply easy to remember the course of an antibiotic. So where you have to take medication for a long time. It's the same experience people with diabetes or say thyroid related issues or say hypertension can also experience. So side effects, I think discussion around the side effects with the doctor. I mean, individual side effects can be very challenging for some. Some may be very minor. Some may be really life-threatening. So I think as and when the side effects emerge, I think you have to discuss that with the doctor, and probably the doctor will be able to find out what can be the best means to assist the person to mitigate the side effect that they experience.
The other question, which which you already answered, but it was asked, like, how long must the patient take medicines? Does she have to take it lifelong? So
I think I also forgot to answer the previous question. I think this was around alternatives. Uh, uh, People actually have a choice to decide what they want to do. There are alternative treatments available, but I think from a scientific evidence-based point of view, I think most evidence at this point of time points to the fact that medications are probably the most scientifically evidence-based. At least the allopathic medications are the most scientifically evidence-based for these two disorders. There are alternatives available. It's a choice that as an individual and as a family, people sometimes make. And sometimes it's probably over a period of time that they think the experiences that shape their decision making finally. So at least if you consider research evidence based, I think allopathic medications have a fair degree of evidence. Of course, there are side effects with medications. One has to deal with the side effects as and when they come. So some of the side effects, say for example, many antipsychotics can and do cause say weight gain, can cause diabetes, can lead to hypertension over the long run, can have issues with the lipids and cholesterol. So these can be challenges that can add to the burden of problems that the person has. So as and when they emerge, I think the required changes to medications, required lifestyle changes need to be made. So the alternatives are there. I mean, people sometimes choose to look at other forms of treatment like say Ayurveda or homeopathy. But it's a personal choice. But again, as allopathic doctors, we generally realize that evidence base is available for the medications that are there. Add-on treatments, say for example, yoga can be beneficial. Making other lifestyle changes like say having an active life involving a good amount of physical activity, dietary changes, all of these can be beneficial. If you choose to take both forms of treatment, I think you should discuss with the allopathic doctor about the kind of Ayurvedic treatment or other forms of treatment that are being prescribed. I think they would look at interactions that can sometimes happen with both forms of treatment. So I think that is something that you should openly discuss with the doctor that you are consulting.
Yeah, the transparency would help. Otherwise, it could interfere with each other.
Yeah, there is a possibility of an interaction between the drugs.
And does one need to take it lifelong, these medications?
As I mentioned, both bipolar disorder and schizophrenia for most people is a chronic illness. As I mentioned, it may be a low dose of medications that may be required for the long run. Now, how long, it is difficult to say in an individual person, but somebody who has had more than one episode or multiple episodes perhaps would require long term.
Okay. Yeah. Sachin, would you like to take it forward?
Yeah, thank you, Saraswati. Thank you, Dr. Krishna. Thank you for the wonderful questions and the answers given. Doctor, I just wanted to take it forward by asking, can tapering of medicines happen at a certain age for the same condition? Thank you.
Yeah, I think if somebody is asymptomatic for a fairly long time, usually for 2 years or more, doesn't really have major symptoms of the illness, you may discuss this with the doctor and decide on tapering the medication. Now, it is up to the doctor, and depending on the kind of past episodes that the person has had, the severity of the episodes, the inter-episodic recovery that the person may have had, I think it's a collaborative decision making. There may be an element of relapse when there is this complete stoppage of medication or discontinuation of medications. How to prepare oneself for that relapse, how to identify early signs of the relapse. I think all of this should be a part of the discussion that one has with the doctor when this may happen. So it is likely that people who have had multiple episodes are at risk for another episode. The probability is higher, and discontinuation may be associated with relapse. But preparing oneself, I mean, if one believes that this is something that I don't want to take at this point of time because I have done well really for 5 years. Sometimes when the probability is explained, depending on the condition, people choose to take medications or say may wish to reduce the dose of medications. But there are people who believe, no, I don't want medications. I've taken it for 5 years. Now I've been completely free of symptoms. So let me take the risk. So they decide to take the risk. And then it's individual experience that matters. But preparing oneself for the relapse, preparing the family for the relapse, I think should be a part of the decision making, collaborative decision making that happens.
No, thank you, doctor. Doctor, the next question is, what is an ethical prescription? Is it being ethical as per the books or as per its the curative effect on the PMI? I believe the two converge very rarely.
Ethics about Sachin,
so what is an ethical prescription? Is it being ethical as per the books or is it as per the curative effect on the person living with mental illness? I believe the two converge very rarely. This is a question from one of our family members, comparing a textbook prescription to what is actually given to a PMI in the real world scenario.
I think sometimes what happens is people change doctors and people can actually have issues with trust with doctors, and sometimes social or societal beliefs around allopathic treatment can also shape people's beliefs surrounding medications or the kind of treatment that has been prescribed. Most of us go to a doctor with some degree of trust, with some degree of belief that the person is qualified and the person knows how to deal with the illness or the symptoms surrounding the illness. So I think it is with that belief that people go. So it is sometimes difficult when, say, symptoms don't improve or when the doctor doesn't provide sufficient time. So I think these are all challenging situations, or some complications, unforeseen complications develop, or there may be situations where people may be frankly negligent. So all of these can lead to issues surrounding trust, and I think that is when people start questioning the ethics of the prescription. We go with the belief that most people are qualified, and the standard of teaching or the standard of clinical competence that people develop as doctors is sufficient for them to be practicing and providing a prescription. So general belief is that they would be expected to be ethical. Now, I think it is with as with any other practice or any other facet of life, that people can have variable experiences in the user and provider context. So I think to say that, to bracket everybody in the same thing would be wrong. To say that people don't have experiences that border on unethical is also probably not true. So I think it's individual experiences sometimes that shapes beliefs around this. So I think it's a very difficult question to answer in a yes or no, because it's hard to vouch for somebody's ethicality, and hard to also say that everybody and brush everybody in the same thing, saying that people are unethical. At the same time, I think people sometimes also pass off the cuff remarks, which I mean, you go for a second consultation and somebody says that the previous doctor has not done a decent job. That may also sometimes shape an experience. The previous person may have taken some degree of cognizance of the various issues surrounding the person's problems. It may also be true that people may actually not provide enough time. So what really helps is that I think open and frank discussion, and I think decision making that is shared, where you involve yourself and also get the doctor to involve in the decision making. I think that is sometimes more helpful. Frankly, discussing issues and challenges at the beginning itself, rather than waiting for issues to happen, would probably be more helpful. So it's a very roundabout answer that I have given to your question, but I think there is no yes or no answer to this question.
No, thank you, doctor. Societal pressures are real. I totally understand and agree. And what you mentioned is absolutely correct. There's one more question from our family members. The question is, I see a few behavioral changes, but I'm scared to let the doctor know because he will increase the dose of the medicine. What should I do?
I think it is tied to the frankness of discussion that happens with the doctor. And I think changes in behavior should be, and I think in the beginning itself, what would be a quantitative change that you should discuss with the doctor? I think this should be a part of the discussion that happens with the doctor, depending on what the mental illness is. Say, suppose it is bipolar disorder. So, what are the symptoms of hypomania? That these may be very individual specific, and we see that many a times these are recurring patterns. So the patterns are usually very similar. So what is it that, and people sometimes individually are also able to realize, people who have some degree of insight are able to realize that there is a change that is happening in me. There is a feedback that the family sometimes provides to them, that you're talking more than usual, or you're spending more than usual, or you're sleeping less than usual. So I think all of these should be part of repeated discussions that happen in the consultations. I think consultations should not simply revolve around medications or titrating medications. I think it should also revolve around some degree of education about the illness itself, the relapse that the person affected may have. I think this also becomes important. Also, other life goals that one has. So I think some of these changes may also be sometimes related to life goals or inability to achieve the life goals, frustration. So I think each of these should be discussed in the consultation. I think then only, and I think over a period of time also, clinical competence and clinical teaching in medical hospitals also revolves now not so much on prescription alone, but also on communicating with patients, communicating with families. I think people are also more trained now in dealing with the issues not only surrounding prescription, but also other issues surrounding life.
Doctor, it's been a very wonderful conversation, and I think I and Saraswati have really gained a lot of knowledge within the short span of time when we have spoken to you. The other question is how to make involuntary admissions hassle-free.
That's not an easy question to answer, because I mean, involuntary admission would mean that the person lacks insight, doesn't believe that he or she has a problem, and requires to be taken to the hospital because the family believes that the person is either dangerous to oneself or dangerous to others, and the family is actually not able to cope with the problem. So the only way probably is to, I mean, people choose different ways of dealing with this situation. We see people simply say hoodwinking the person and bringing them to the hospital. We do see people who immediately take them to the or call the police to help. Sometimes repeated convincing or some degree of subtle coercion people do. And then we also see people who listen to a few family members but don't listen to others. So they may use the good relationship that people have with the family member or a friend and bring them to people. So there's different methods that people use. So I think all of these should be tried. I think extreme actions like, say, for example, use of force or use of external help, like, say, the police, can sometimes be very counterproductive in the long run, because what happens is people then tend to associate the person who has done this with this force or with the external help that is taken. So, but I do agree that sometimes it can be an extreme degree of challenge. Sometimes it is the comfort that they have with the person. Say, for example, they may wish not to come to, say, NIMHANS, but might want to go to a private psychiatrist, which may be completely okay. I mean, people need not necessarily come to Dr. X or Dr. Y. So I think giving options or some degree of comforts. I have seen people who have consulted a general physician, and because the general physician then advises them to go to a psychiatrist, they may feel, okay, the general physician is advising, the family is not advising, the general physician is advising, so they'll follow the physician's advice. So it can be circuitous sometimes, it can be difficult sometimes. But I think trying to convince the person by tying it to needs, as I mentioned, then say using the good offices of a family member who the person feels is non-threatening, or the intent is not bad. So, or say a friend. Then going in extreme cases, probably you might need to take the help of the police. It is not true then that everything will become hassle free. So again, there are challenges post admission as well.
Oh, thank you, doctor. Because we've heard that the new Mental Health Care Act. So when I and Saraswati was speaking to a lot of doctors, they have said that there are certain things which have also made this difficult in the new Mental Health Care Act. So that was a very wise advice. To just take it forward, there were a few questions on insights and behaviors. One question from a family member was how to bring about the value of money and impulsive spending for the person living with mental illness. How do you actually counsel a person or tell a family on how to actually change these behaviors or address these behaviors? So the question is value of money and impulsive spending.
Yeah, I think it depends on the kind of mental illness that the person is having. Say, for example, in the context of say bipolar disorder, spending money or overspending may be a symptom of the illness itself. So, if it is because of the illness, I think taking adequate treatment would be the solution in such a situation. Sometimes we see that each of us is different in terms of our nature, in terms of our personality makeup. So, some of us are take a decision on the spur of the moment, and some of us think a lot before we take decisions. So I think people with the mental illness also are likely to have individual personality makeups. So impulsivity may be, or this very on the spot decision making may be a very personality characteristic rather than a symptom of illness. So I think there cannot be a perfect answer to this question, but I think it depends on what the person's personality makeup is, whether it is a symptom of the illness that the person is having. Again, I think frankness and discussion around these with the doctor may be helpful. So if the doctor probably doesn't have enough time or doesn't believes that you may need to consult a psychologist to take help surrounding these, I think that is something that the family should be open to, because they may, in the course of talking to the patient and providing counseling, they may be in a position to probably understand this also better and then provide advice or give a feedback to the doctor and maybe in a position to help. So I think it may depend on the situation that these people. So it may sometimes be that this may simply be a degree of casual behavior or a learned behavior over a period of time. So I think it may then be very purposeful. So it depends on the context that one is dealing with. So it may take some degree of discussion with the doctor as to tease out what is it that is happening.
Oh, thank you, doctor. That was a very good explanation. One question we just wanted to address is a lot of our loved ones actually stay with the families. So people who live with mental illness stay with the families. Sometimes there's aggressive behavior and there are older people at home. So how do we handle aggressive behavior towards the family, and how do we actually tackle this when the people are staying with us?
Yeah, I think aggression can take different forms. It may simply be verbal aggression or use of abusive words, or say making gestures which are very threatening, to very frank physical abuse, or say hitting people, or spitting, or throwing things at home. So, so if the aggression is very severe, I think external help might be required to mitigate. If the aggression is say very verbal, I think it helps not to argue with the person, to move away from the place, to say postpone any discussion that is causing this issue, and say not looking into the eye, and say not being very harsh, so that it doesn't aggravate the situation. And if you see that it is escalating, I think then moving away from the place and talking to the person after some time may be more helpful. In situations where there is frank physical abuse or physical aggression, I think one has to simply move away from the place and seek external help. there is no other way because it is not worth the risk. The injury is not worth the risk. You don't need to take that. So, but I think again, becoming aggressive may be a symptom of an illness, maybe a behavioral pattern that may develop over a period of time. To find out why this is happening, I think we might need to discuss individual cases.
Thank you, doctor. Doctor, the one question which always baffles all our family members is how do we distinguish arrogance with the symptoms of the illness? Sometimes you feel that a person is arrogant, or is it the symptom of the illness? How do you distinguish between this in the finer points?
Now, what may be helpful is if there are other ancillary symptoms of the illness. Say, for example, usually this happens in the context of, say, if it happens in the context of, say, bipolar disorder, say in the context of mania. So you will also see that the person has other changes like not only being very irritable, not only being very brash and very brusque in conversations, but also talking a lot of very grandiose things, not sleeping well, being very physically active, not getting tired easily. So being very talkative, which is unusual of oneself. So that I think is very easily recognizable. What is the challenge is sometimes when this happens at a very early stage, say the early features of a relapse, I think that's when the families may find it difficult to recognize. What usually helps doctors is to find out biological changes that happen. That is the sleep-related changes, probably coupling with this might be an indicator that this is a sign of relapse. Arrogance is a part of a personality characteristic or over a period of time, a change in, a behavioral pattern that develops. I think that will not be associated with other symptoms, that will not be associated with sleep disturbances, and that may not be very pervasive. That is usually in the context of, say, particular demands that are not met. And I think then one has to deal with it as a behavioral problem, as a pattern that has developed, that has been learnt over a period of time, rather than medications that may help with that.
Thank you, doctor. This is a very articulate explanation, and it's been really enlightening. I'll request Saraswati to take over and continue the next questions. Thank you, Saraswati. Thank you, Dr. Krishna.
So the other we are nearly coming to our end of our questions. So the other two questions are, will the patient always be suicidal?
No, I think at least with, say, for example, severe mental illnesses, we do see some people who make suicidal attempts. We do see some people who die by suicide. And during some episodes, say, for example, with bipolar disorder, we do have people who experience suicidal thoughts and do have suicidal ideas. So one suicidal, not always suicidal. I think at least this is true that one suicidal, always suicidal is basically a myth and it's not a fact. But I think the context in which these thoughts occur or the context in which suicidal attempts are made need to be understood, because these are really serious issues that need to be dealt with. Now, what happens is that suicidal thoughts may emerge as a symptom of, say, depression itself in the context of bipolar disorder. So it's something that needs to be dealt with immediately, and the family needs to consult the doctor immediately. Now, similarly, suicidal thoughts developing in the context of, say, voices that are very demeaning to an individual, or say talk very badly about a family member. So these can be very distressing for the person concerned, and I think that needs to be dealt with immediately, because then there is a risk that the person may end his life because he's unable to bear the distress surrounding this. So I think this has to be dealt with immediately, and I think it can be a life-saving thing if you take the person immediately. There are a fraction of people who may because of their personality characteristic may make it a behavioral pattern to threaten somebody with suicide. Then there are people who may simply make non-fatal attempts just to relieve distress. So I think it's important that you discuss with the doctor and find out what is the issue that's happening with the family member who is affected and find out whether it's a symptom of an illness, whether it is a part of a distress. See, for example, recovery from a severe mental illness, and one becomes acutely aware that I've had a very severe episode. I have behaved very differently with people or misbehaved, frankly, with people, can sometimes demoralize. And this demoralization itself and this being aware of an illness itself can be very hurting for a person. And they may think that I have done these mistakes. So then there's a lot of guilt associated with that. And that can itself may cause the person to have suicidal thoughts. So it then becomes important that you recognize that and you bring about a frank discussion with the person about how to cope with this change scenario, how to cope with difficulties that have happened, say because of the misbehavior. You may have broken relationships because you have misbehaved with somebody. You may have had loss of a job because you have misbehaved with somebody, because of a acute episode that you had. So I think teaching them to cope with this new change that happens, I think again that becomes important. So I think it's complex in that way. So it can be because of symptoms, it can be because of awareness that I've had symptoms and now I have recovered. It can be because of demoralization. It can be because it's a learned behavior. It can be because people have personality characteristics which predispose them to make such attempts. Sometimes it's not with the intent to die, but with the intent to relieve distress.
The last question is it okay to leave our loved ones alone at home?
To believe that people with mental illness are not capable of taking care of themselves is, I don't think that is true. People are capable of leading fulfilling lives. We do see examples of people leading very productive lives. We do see people who broadcast and disclose their illness to everybody, are able to achieve whatever they aspire to achieve. So I don't think it's a one size fits all and say that people should be encouraged to be independent, to take decisions for themselves. I think it's only very rare cases where people are extremely symptomatic, are not able to take care of their daily activities or independently take care of other important activities of life that they require support. Or if, say, people are suicidal, that is when you absolutely don't want to leave them alone. I think fostering a degree of independence and encouraging them to meet their life goals would be most important. And being alone and taking care of oneself is one important aspect of life. I don't think we should cocoon people to the extent that you are always around them. We should encourage them to be independent. Unless they're extremely symptomatic, suicidal, hostile, dangerous to others, I think a degree of independence should be provided.
So, any last words of advice to our family carers?
I think I saw a lot of questions surrounding marriage and disclosure. I think maybe we could address them separately.
Yes.
These are important issues that family members often come to us with. Work is an important aspect of recovery. I think this is also something that families should probably look at as a goal of recovery. And I think most other issues you have probably addressed. I saw a few more questions surrounding insight. So I think we could take it up probably in another
episode. Yeah, definitely. Thank you so much, Dr. Krishna Prasad. I think the takeaway which I have taken is, being transparent in your communication, not only to our loved ones, but also with the doctor, will give a better understanding of both our loved one and the disease, and what are actually symptoms and what are actually behaviors. It will lead to a better environment at home also, and better. I think the recovery process would be much better. Yeah. Thank you so much, and we really appreciate.
Thank you.